Start record. So, hi everyone. So thank you all for joining us this month for our Kumustahan. This is the last of our series of Filipinas during COVID. Throughout April till now, we've had amazing monthly speakers from people like Dr. Araneta from UCSD talking about health disparities amongst Filipinos and Filipinx, to other speakers as well who've touched upon multiple topics relating to health and disease, especially pertaining to us as Filipinos. This month, we had the pleasure of speaking with Dr. Ninez Ponce. And before we get started, though, we always just want to introduce AFSA and CFAM. So at AFSA, we are a community of Filipino, Filipina, and Filipinx scientists in America seeking to utilize our collective expertise and resources to support our communities in the Philippines and in the US. Jacob, if you want to say CFAMs.
Yes, we are the Council of Young Filipino Americans in Medicine. Our mission is to promote leadership, development in young Filipino American physicians and trainees, reinforce the educational pipeline, and address structural inequalities in health through advocacy, scholarship, and community partnership. We hope to equip and empower all individuals of all training levels to be effective agents in addressing our most pressing health priorities. So thank you all for being here.
Yeah, so before we always get started with Kumustahans, we like to ask a few questions, see where everyone's at, what people are studying, and just get to know our audience. So first one is location and area of study. So whenever you all are ready, just rapid fire answers in the chat. So it seems like we have people from all over the US, from Las Vegas to California to New York also. And another Midwesterner in Indiana. I am currently in Minnesota, so hello. And then we span across all different kind of disciplines. So this might be an odd one, but favorite Filipino singer, anyone? So Lea Salonga, Moira, her also. And we have more Moira and her fans and Leia fans also. So yeah, now for the person you've all been waiting for, Dr. Ninez Ponce. So Dr. Ponce got her bachelor's at UC Berkeley, MPP at Harvard, and PhD at UCLA, and she is currently a professor in the UCLA Fielding School of Public Health, director of the UCLA Center for Health Policy Research, and principal investigator for the California Health Interview Survey. Her research contributes to the elimination of racial, ethnic, social disparities in health. She is an elected member of the National Academy of Social Insurance and has served on the Board of Scientific Counselors, National Center for Health Statistics. She has received numerous awards from community organizations recognizing her work in community engaged research. Dr. Ponce champions better data, especially on race/ethnicity, social determinants of health, better inferences on communities of color, better population representation of data, especially for those that are typically invisible in administrative and surveillance data, and better care for overlooked groups. So can you also, can all of us just give a warm Zoom welcome to Dr. Ponce? And then I'll stop sharing my screen. So, okay. Floor is all yours now, Dr. Ponce.
Great, thank you. This is where I work with the unmirrored image, the UCLA Center for Health Policy Research. So I'm so happy to be here. I have some slides. I believe we're on until 5:30ish, or I'm in LA, so West Coast time.
Yes.
And so I'm actually gonna play I'm a little bit embarrassed about this, but I got an award a few years ago from a community organization called Asian Health Services, and they had a fabulous storyteller camera person. And so they did a 6-minute clip on kind of what makes me a researcher. And at that time, they called me the people's researcher. So I think it's a good introduction, a bit of who I am before I get into my conventional PowerPoint slides on what I do. And this actually talks a little bit about what I do. So I will also, I'm just curious if anyone has read, hello, Homicide and Hollow Hollow or Arsenic and Adobo. Just curious, either one of those, because I'm in a book club and I may tap on you so that I can cheat a bit and finish it. Yes, okay, great. I love Arsenic and Adobo, but actually the Homicide and Hollow Hollow was a little bit slower, but Arsenic and Adobo is fabulous. All right, so that I'm good now, share my screen and hopefully I can share sound, and I'm going to share this and then I'm going to enter full screen. It's 6 minutes, so bear with me and indulge me on this.
I would describe Ninez as very driven in her work. It's her interest in the community, her interest in community health, it's her strong interest in health equity that drives her interest in developing the research that impacts the public policy.
She's able to be the communicator between community needs and those who have the resources and the social will to make a difference. I grew up in Manila in a very tiny street. We call it like Esquinita, in a very tiny flat. My dad, while he had a good job, he was an accountant, and my mom was a teacher. They still felt they were stuck, particularly in the Marcos era. My father left the Philippines in '67 and petitioned for us, and my mom and I joined him in August of 1968. I was 6, and we arrived in San Francisco, and we first lived in the Tenderloin. My mom did not have a job, tried to get a job, and I just remember her crying every day about why did we leave the Philippines, our support system. And it wasn't until like they just continued to grow into their career that it got a little bit better. I, of course, had an accent, and I remember people thinking I was Eskimo. At that time, it was mostly Irish and Italian Catholics in this Catholic school that I went to. Like a lot of immigrant families, my parents, of course, wanted me to be a doctor, and I went to Berkeley as pre-med and got very involved quickly with the Berkeley Free Clinic. That's where I learned that healthcare is a right, not a privilege, and it was my awakening of public health and population health. So I went to public policy school, where I was taught it should be the data that speaks. That thinking was very useful in my first job at the Asian Pacific Islander American Health Forum, but I was disciplined by Sherry Hirota, who was on the board. And when I said, "You can't do advocacy," when she says, "What do you mean you can't do advocacy?" She absolutely valued evidence and data, but without any heart and direction, it's really meaningless. Sherry taught me about this balance of evidence and advocacy. and the two together could be very powerful. I went on to get a PhD because as a young woman, you're automatically like, you're not the expert in the room. And so the credentialing was important to get those research creds. And that's how I got into caring a lot about the quality of good data.
The California Health Interview Survey is kind of an ongoing survey of the California population that tries to measure a lot of things around health insurance status and health status and looking at health disparities and health equity in California. Data to use for reports or analyses or for briefings for elected officials, for policymakers. It becomes like the Bible. It's like it came out of UCLA, it came out of CHIS. You know it's reliable. It's reliable because of the work that she's done to make sure it's reliable. So she's been such a champion of that.
So public charges, oh, you might be a burden to the public system. So if you're an immigrant, if you use cash benefits, then that could go against you when you apply to get a green card. The rule that was finalized, that was published in August, adds non-cash benefits, basic needs of health care, of food, and of housing. What a lot of people don't know about public charge is that it's an attack on legal immigrants. It's an attack on lawfully present immigrants. And a good portion of lawfully present immigrants are from Asia. The One Nation Commission is a group of mighty influencers and researchers and community organizers who were brought together by Sherry Hirota and Congressman Mike Honda to fight public charge, to fight this rule.
The data that Ninez is putting together on public charge is really important to us on the policy making side and those that are working on public policy because we'd like to be able to use that data to say, gee, we really can't let this happen. She's quantifying the concern for us so we can change public policy to better address the number of people that might be affected.
Ninez has a real sensitivity to the experiences of immigrants and migrants, and I think that our desire to see research being used as a tool for social change is a very important common element that I feel that she and I share, both philosophically, emotionally, and psychologically.
So last year was the 50th anniversary of my mom immigrating to the States from the Philippines, and I was at school. I had had a terrible day, but I was thinking about how thankful I was for all the opportunities that I had. So I gave my mom a call. When I thanked her for everything that she did for me, she kept on saying like, oh no, it was all Lola and Lolo.
I've been very fortunate to have many mentors in my life. The two most important ones are my parents. My father, I think I get his precision. He was an accountant. And then the passion to make lives better, I think comes from my mom. My mom, the teacher, and I think my parents left me that legacy of being kind and sharing as much as you can.
Okay, thank you. Again, never shown that to a group, thanks. But it was 2 years ago, and just as an update, thanks for all the hearts. I hope some of my stories resonated with some of you. And we were able to provide evidence that actually was used in several court cases in the former presidential administration. And some of my research was used in some of the lawsuits against the Trump administration. And now the public charge actually, the law that came in effect in 2020 is now rescinded. So it's back to the old, and possibly even looking into not enforcing the cash benefits piece. So gives you a little portal. I haven't I'm not going to show you this other video. This other video talks about, as you notice, I'm an only child, which may, not be the mode of Filipino families, but I talk about having my own room. And but as an immigrant, I thought it wasn't being lucky having my own room, because we ended up opening the door for anyone who showed up from family and friends. And I never had the room to myself because we were always helping out new immigrants, coming here. And so again, this legacy from my parents of sharing. And I like to share data as well. So let me get now to my presentation at 4:49, and we can get at. So, kumusta? My presentation is no equity without data equity. I've just been sort of my battle cry the past year, particularly in light of the invisibility of the Filipinx community and other communities during the COVID pandemic. And that invisibility leads to policy neglect and continues this vicious cycle of leaving some groups behind without the opportunities that are needed but are undetected. I just became an endowed chair as well as a center director. So I'm an endowed chair in health policy and management. And I also, July 1st, became an associate editor for JAMA Health Forum. I think most of you know as scientists what the power of data is, power of evidence, and that has to be rigorously done. And so it keeps me up at night. So I'm going to have some stories of the California Health Interview Survey, which you heard Richard Figueroa, who's a special assistant to the governor of California, on the California Health Interview Survey and what it means. But what data equity is, I'll describe in the next slide. Some data failures during the COVID-19 and in general. I kind of cut some lessons and recommendations because this is a crowd to talk about, kind of the production of knowledge and how did we get there. But I can talk about more of lessons and recommendations for the Q&A. So my examples are the California Health Interview Survey, and then this race ethnicity data disaggregation that's really gaining a lot of movement. Certainly, a hashtag on Twitter, lots of different disciplines and researchers that are taking like the data equity piece in a lot of their scholarship and their work. And two examples during COVID are the Native Hawaiian and Pacific Islander Data Policy Lab and the Filipinx AO Community Health Association. So measurement is key to achieving this notion of health equity, and health equity being giving people what they need. It's not equality. It's not giving everybody the same share. It's not giving, everybody the same, piece of that chocolate cake, as Deborah Stone would say in public and political science, but it is giving people what they need. And oftentimes, some groups need more things just because there's been generational, historical, environmental injustices, and those have to be addressed. But for the CDC, they have 3 lanes of getting at health equity in a stylized view of how to get to health equity. Programs, which is successful health equity strategies. There's policy, then the laws and regulations, the rules that are made up, such as public charge, which would have really mitigated the opportunities of new immigrants to have a better life here in the United States. And then there's a middle lane, which is actually the lane that I inhabit or I drive on the most. It's the measurement lane, and the measurement lane is data practices to support the advancement of health equity. What I do say a lot in my talks about this middle lane is that you do have to stop a lot and take in people in your car or in your van, folks that are from the community with the lived experience, because measurement siloed without really getting community input, their voice, their engagement, then it really is not getting at this notion of what I call data equity. And data equity is when data are collected, they're analyzed, they're interpreted, and distributed such that the marginalized communities have a say in the design and access and use of these data. So it's not just you collect it and then you use community groups to disseminate it, or it's not that you use community groups to recruit so that you can have some diverse sample, but that they are there with you in the whole design stage, the collection stage, the analysis stage, and the use of the data. Of course, some community groups may not be at that point or do not have the capacity, but at least some accountability is needed and some way that you get their engagement to make sure that what you're collecting really is meaningful for those communities. So my first story, the California Health Interview Survey. As you saw, I was an advocate before I was an academic. And I think this advocacy pedigree that I had was what helped with trust from community and community partners, and why I got like the People's Researcher Award. And it's because I continued to, when I became an academic, continued to engage with communities, get them, at my blueprint while I was designing the survey of how, what we could do, how we could do better. So I do tell folks that you don't have to have had these credentials or this pedigree of community organizing and engagement, but listening to community definitely helps. And the CHIS, the California Health Interview Survey, we are the nation's, this is my brag book, we are the nation's largest state population representative health survey. We're not BRFIS. If some of you have used behavioral risk factor surveillance system, it's not BRFIS. It's its own self-finance program. It is not government, it's not federal, state government. It is actually have about a dozen funders. I'm also a data entrepreneur. So I do like a bake sale every 2 years to fund a survey. And it's a big sale because this survey is about $10 million a year. And it's the most comprehensive source of health information in Californians. Thank you, Richard Figueroa, for saying that. And that it is built on the strength of community-based partners and advocates that need to use this data to address their specific needs of their service population and for providers to serve their patients. And I think what I like about the survey, or what I strive for, is that it's not just about what happens in clinic walls. I know most of you here are med students or are, or will become med students or are actually professionals, but it's really not about just the clinic walls. And we do ask, of course, about doctor's visit, usual source of care, ask about chronic conditions, but it's also that backstory that more and more we know that we have to take the whole person into account of the patient. The backstory of the living conditions of education and where they work, income, any traumatic history that occurred. So we're piecing this together, and this could possibly explain then or help with designing programs on explaining the racial inequities and getting rid of eliminating the racial and health inequities in health and health outcomes. So I'm also very proud that since I was a designer of CHIS from its inception, which was 2001, CHIS is like now, it's 21 years now. CHIS is an adult now, is that we have this, we wanted a big enough sample that we could provide sub-state local estimates. Because a lot of service delivery, like in mental health in California, may be different in different states, but a lot of service delivery happens at the local level, at local health departments that are typically at the county level. And so you need to have a big enough sample that you can generate insights on what's happening in your local communities. There's something called, there's another survey tool that I do love, the National Health Interview Survey, but that's for Health USA. That's for the health of USA population. You really can't get at state estimates or even sub-state estimates with the National Health Interview Survey. And in the beginning, CHIS was patterned after the National Health Interview Survey. And then we want to also, this is where I came in and I said, well, let's not just have that goal of local estimates. Let's have an explicit equity goal. And this is me talking, 20 years ago. I don't even think health equity was in the vernacular, was to measure then health disparities in the state so that we would have enough sample that we can get at race, ethnicity, language disparities, sexual orientation. We didn't have back in 2001 gender identity. The measures weren't even there yet, their awareness, but now we do have a gender identity question. And citizenship, immigration status, absolutely important, since a lot of our eligibility rules to get at public safety net programs are based on both income and immigration citizenship status, disability status, and of course, educational attainment, occupation, income. So all of the asset factors or deficit factors, whatever these factors are that ensure that a person has the best opportunity to have the best health possible and to live the best life possible. So if we center equity in population surveys, and I have an article in this in JAMA Health Forum, where then, so you have to have an explicit measurement objective to eliminate health inequities. I think that that's key, because then I don't have to convince my dozen funders. I don't have to always say, please fund us. And by the way, we want to eliminate health inequities. It's pretty clear. This is what we want to do. And also that we are co-produced we're co-produced, it's not just our researchers. My CHIS team at the Center for Health Policy Research, there's about 25 of us. It's a team of statisticians, mathematicians, survey research methodologists, questionnaire design experts. But it's not just us producing this, but it is co-produced by our partners through an advisory process. And then we also have this organizational commitment of community accountability. So we report every year, like what we do. And we also make sure what's actually not here is that this notion of data doesn't sit on the shelf, that we democratize the data. We democratize it through public use files. We democratize it through free lookup systems, lookup query systems, free mapping systems. And also we have policy briefs and fact sheets and we put out social media when we have a product to put out. So with these in mind, then the quality of insights that are used from the data will improve, and population health will surely improve. So how have we impacted data equity research? It's that it stems from these factors of collecting a lot of sociodemographic information. I think maybe about 500. I mean, it's a lot, and we try to do it in a not overburdening the respondent. When we used to do telephone, we used to be a telephone survey, and now we're a address-based sample and a push to web. The approximate time is about 40 minutes. We really tried 30, but each year there's just so many, particularly during COVID, so many problems, had to be unearthed. So we had to add some more questions for CHIS. And we also look at, I think what's relevant here, at Asian and Native Hawaiian Pacific Islander subgroups. We also look at American Indian Alaska Native tribal affiliations, sexual orientation, gender identity, And then beginning 2021, in line with the change in the Census 2020 questions, writing categories for the white and the Black African American group, a way to capture the Middle Eastern North African population. We oversample for 2 Asian American, Native Hawaiian, Pacific Islander groups, the Koreans and Vietnamese. And we've oversampled also for American Indians, Alaska Native, and Black and Latinx oversamples in some areas. My early research was on language access. And my argument was always, how can you talk about language access? Before it was, there's no problem. Well, there's no problem because the surveys that the federal government was using was English only. So how can you say there is no language problem if the surveys are English only? So this is like what brought on this, like we have to conduct interviews in a variety of Asian languages. And we collect in Cantonese, Mandarin, Korean, Vietnamese. And recently, well, since 2014 in Tagalog. I got a lot of flack from Filipinos, like, why didn't you do Tagalog since 2001? And I had to say that we're also a scientific product. I can't do it just from, oh, I mean, I really think, we should do it in Tagalog. We actually looked at, linguistic isolation from the census, and we looked at the probability of capturing the population in a probability-based sample. And Filipinos are always like number 1 or number 2 in California. So we would catch them, but the linguistic isolation, at least at the time in 2000, was not high enough for that threshold of interviewing in Tagalog. But then in 2010, because of demographic shifts, because of family reunification, of petitioning for your relatives, and some of them may not have come in during the professional tide in 1965, that we actually saw higher linguistic isolation, and it was enough to justify adding Tagalog. So now we do it in Tagalog. And then recently conducted a tobacco survey of adults for 2 groups. We went to non-probability space. It freaked out my survey statisticians, but we had to do it to get at these smaller groups, NHPIs and LGBTQ. So I like to use this as the tsunamis. It's a good tsunami. And because it's a tsunami for production of knowledge, and how having a data like CHIS actually then led to this proliferation of studies on Asian subgroups. It's by no means causal, but it's, I think I'll have some other, but most, I'd say the preponderance of these studies between this period and, this period here were used data from the California Health Interview Survey. So again, data doesn't sit on the shelf. It's got to be used. It's got to be used to bring back, insights to a community. And I just put here, for those of you who are interested in policy, some key milestone policies that try to get at data disaggregation. But my argument here is policies are important. They're a foothold. They're your production possibilities curve. I'm a health economist. Production possibility curve then is widened. However, until you have explicit measurement objectives, such as what we did in CHIS, then you're not going to create. You need to have that material, that fabric, to then analyze the data and publish that data so that Filipinos and other Asian and Native Hawaiian Pacific Islander subgroups are in the peer-reviewed space. So I think I adding some more key things here. And one of those papers is actually a paper with my colleague, Alexander Adia, and also I got to get to know Jennifer Nazareno and Dawn Apirario. They're all from Brown. And Alex is now doing a PhD at Berkeley. But we set forth doing some papers using CHIS. We have about 4 of them. And this is the first one that looked at subgroups and looking at health conditions and outcomes and service access. And so if you look at the article, it was in American Journal of Public Health in April 2020. We wrote this pre-pandemic, that the Asian subgroups, definitely that there were, when we disaggregated them, that there were some groups that had much higher health need than an Asian aggregate category. But we saw that Filipinos in particular had the most disparities identified after disaggregation. And the conditions, were like mental health, asthma, obesity, diabetes, and hypertension. So indeed, a key finding was that Filipinos appear to be in the worst health of all Asian subgroups, which suggests a need to address Filipino-specific needs in future policies and interventions. Another key finding was, in contrast to this, was paradoxically that there seemed to be an overrepresentation of Filipinos in the healthcare field. So health, burdened by health conditions, but also paradoxically, a representation in some cases, in some specific clinical fields, an overrepresentation of Filipinos, which kind of gets us to, stop moving, a special sample. So let's talk about COVID now. With UCLA Asian American Studies Center, we actually got funding from the California State Legislature. There's enough Asian Americans in the state legislature that they have a caucus, and this caucus was very vocal in with a series of the much publicized hate incidents during the COVID-19 pandemic against Asians, particularly the victimization of Asian women, that the legislature then got general funds money to give funds and sponsor research that would provide insights on hate incidents. So we worked with the Asian American Studies Center at UCLA, and we developed a module very quickly on COVID. We got this out, so we were in lockdown the middle of March of 2020, and this went in the field around July of 2020. It sounds like a lot of time, but in a large population survey project like ours, that was as nimble as we could be. We were very nimble in getting these questions out. And we looked at hate incidents, and these could also be disaggregated. These are among all Asians, Native Hawaiians, and Pacific Islanders. I have a paper coming out in the American Journal of Public Health where we disaggregate these groups. I can't scoop it, so I won't tell you what the story is behind it, but it will be coming out. And we looked at, and this is like why population health surveys are important, because if you look at, the API hate, the registry, right, is the Stop API Hate, is that it's just those who experienced an incident, who had the courage, and it's to report it, and then whatever national crime victimization groups say, then what they deem is actually what is elevated to a hate incident. So the numbers are, like in the thousands, but if you look just in California, we actually got the 6.8% reported directly experiencing a hate incident due to COVID-19 over the past 12 months. And actually, we asked a question about witnessing as well. And so 1 in 4, 25% reported witnessing another Asian or Native Hawaiian or Pacific Islander being treated unfairly due to their race, ethnicity, or national origin. In numbers, there's about 6 million Asian NHPI adults in California. So 25% of that is 1.5 million. So that's more than the city of San Francisco. So it is a pandemic. It is an epidemic in its right. And you couldn't just get that from registries, but from a population-based survey. just some male female slice of the data. More females than males. I don't have confidence intervals, just gives you a sense of the point estimates here. And again, more females than males in witnessing. So there's more to that. I'm going to go quickly into my data disaggregation. The Native Hawaiian, okay, so I also have funding from the Robert Wood Johnson Foundation on data disaggregation and technical assistance. And here's it's been a journey since, when I was an advocate, I've been championing data disaggregation for a long time, but it's a 30+ year journey. But here's my recent activities, because you'd be here the whole day. Well, you saw the video, so it gives you a bit of a portal of my 30+ years journey. NHPI Data Policy Lab. Again, I think, most of us now consume stories and media much more quickly than reading, a whole journal issue, but we still should be reading journal issues. And it's this was in the PBS NewsHour. They contacted me because they had heard that I was doing some work with the Native Hawaiian Pacific Islander population. And so I think the crux of this was when the pandemic started, the NHPI population was showing the highest case rates among the 5 major racial ethnic groups, the 5 being Latino, Hispanic, it's ethnic group, and then American Indian, Alaska Native, Asian, Black or African American, and the white group. And in the beginning, since we were just getting data slowly, I got asked by reporters, is this just a small data problem? So sure, it's huge, but it's because it's such a small population. And so what I did was I worked with community organizations and found out that they were going to funerals pretty early on. They had heard about outbreaks in Arkansas, in the Tyson's chicken plant. And so kind of that's, again, community partnered, like ear to the ground, was then I looked at, well, what's going on in other states, what's going on in Hawaii. It's kind of like doing the detective work, as we all do as scientists. Like, is this a real, is this a phenomena that's for real, or is it just a glitch? Is it a small data problem? And so through that, we started just scraping data. I started scraping data with another colleague of mine from UC Irvine, Brittany Morey, great work on structural racism. And so then we started, then the advocates said, we need you to do not just California, but I'm going to do a testimony for Ways and Means, and I need something on Illinois because there's a congressional representative from Illinois, and I'm sure she's going to ask me. So we started looking at Illinois, and we started looking at, it's not just about Utah, but can you do Salt Lake? It's not just about Oregon, but can you do Multnomah County? Not just about Seattle, but can you do King County? So it just scraping, it ended up, I had to say, I kind of have a day job. I run this big survey and I'm a professor and I run a research center. And they said, well, why don't we give you volunteers? And so, then 4 Native Hawaiian and Pacific Islander volunteers and their friends actually started helping scrape the data. And luckily, one of those volunteers and his friends were from the University of Chicago, doing a master's in computational analysis and public policy. And then they automated our manual scraping into a Python program. And then we and then said, well, it's not enough that we do this on demand. Why don't we do it? So we'd have a dashboard. And so it's ready for folks. So that's kind of the story. We worked with a representative, a leader in the Marshallese community in Arkansas. And so we helped with showing the data and talking about how to speak about the data and showing some graphics. And so this is just an example of the very simple Tableau dashboard, but very striking in the story where the orange line are the Native Hawaiian Pacific Islander population. And again, looking at patterns, like a lot of what we do, right, is just like pattern recognition and seeing is this just just one exceptional case, or are we seeing that something is happening in different places? And so this is what we were seeing. And then another just example of, we see a lot of data that's where Asians and NHPIs are lumped together. And actually for Asians, because we're the larger group, it doesn't really change the Asian alone. I mean, it's like Asian separated, but it does affect NHPIs. It really does mask the need of this population, because here's Asian NHPI is 75. But actually, if you disaggregate it, this is 75 per 100,000 deaths in California in 2020. But then if you disaggregate, then you actually have much higher rates in the aggregate and in disaggregated groups. This data, by the way, took me like a year to get, because it was not public facing. I had to get it through a Freedom of Information Act just to get at this disaggregated piece. And then, so you can ask about Filipinos, right? So for Filipinos, then that social movement, then I started getting questions from my colleagues saying, this is wonderful what you're doing for Native Hawaiians and Pacific Islanders, but what about Filipinos? And why can't you do some of this? So, and actually what had happened was the stories Filipino ex-AO Community Health Association, and forgive me if some of you here are members. If you are, mabuhay. If you're not, you should consider being part of this group. So this group, so it started with, and I'm sure Dr. Araneta Happy, my colleague, we both were on this we're both commiserating over the invisibility of Filipinos in data, and that the only real public-facing surveillance system on the pain and the loss in the Filipino community was through memorials and elegies and online tributes. Lovely. And so actually one of the first ones was from Kanlungan, and where they were crowdsourcing. They basically looked and scraped through GoFundMe and Facebook and Instagram, and looked at any mention of Imelda was born in the Philippines, or Gustavo enjoyed Filipino food. So just any triggers that this could possibly be a Filipino health worker, that's how that was done. And it was lovingly done, volunteer, but actually scientifically done. They had more than one scrapers to make sure it was high quality in what they were putting in their map. And so that was just, so we started working with the group, a firm that started that. And then we started thinking more about the data. And again, getting restricted data was the only way we could get at what was happening in the Filipino community during COVID. And this is where we're seeing that healthcare workers are disproportionately affected by COVID. Filipinos are 3% of the healthcare worker population, 31% of COVID healthcare workers' deaths. Very hauntingly similar to a National Nurses United study that had very similar juxtaposition of low, about 3%, I think about 4% Filipinos are nurses, but yet about 31% were attributed to nurses' deaths were attributed to Filipinos. So basically the same story here, but here it's where Filipinos here on the bottom, where in disaggregated data, again from restricted data that I somehow got, is that Filipinx the share of COVID deaths are here much higher than the share of the population, and just the leader in loss compared to all other larger Asian American groups here. So it's this was published in JAMA and Health Forum. And so all this came about was that we started this group called Philippine X80 Community Health Association, or PhilCHA. And so we were meeting, we were writing letters to the Biden administration. We wrote letters to vaccine equity, committees, and it was, but then we thought we had a responsibility to share what we knew, to the public. And so we got a grant through APCHO via the Walmart Foundation, and we started a podcast. And it's Filipinos sharing stories together, or PST. So we had this podcast now over, but I think it's now on, I think it may be on YouTube, but it is now available. And it was just from podcasts of folks like Dr. Arnetta and myself, but also on folks from LA County Department of Public Health talking about myths and facts about the vaccine, talking about taking care of yourself, mental health during this period. So it was, again, another feature of this PhilCHA. And then lastly, what time is it? Okay. This is Melanie Sabado Liwag, and she's a colleague that in PhilCHA that led one of the papers of PhilCHA. We've been pretty productive. I care a lot about data infrastructure, obviously, with the California Health Interview Survey. I care a lot about community academic partnerships with the labs that I started that were community labs. And but we're being productive. It's these are just 3 sample papers in high impact journals that we wrote together as members on, and also in KCET and also in public media. But and then the technical assistance in the pipeline building is, as a professor, as a chair now, and as a research center director, that it's really about the pipeline building and the how to that keeps me up at night. And so I hope we're okay. Is that only 4 minutes now? I'm so sorry to have dominated that, but
So
I'm done, John Ray.
Yeah. Thank you, Dr. Ponce, for your amazing talk. So while people can raise their hands for questions, let me just share my screen and do some last minute things. So if you're interested in getting involved with AFSA or CFAM, plan more events like this, just reach out to us or find our websites here. And then for us at AFSA, we also have a mentor-mentee program starting up soon. So also just be on the lookout for that, or reach out to one of us on AFSA. And so if anyone has any questions, feel free to raise your hand or unmute now. Dr. Ponce, can you stay a few minutes after?
I can. I'm so sorry I took up all that time. I told you had to stop me because I don't look at that. I get so involved and I don't look at the chat. But I'm seeing some of yes, you can have a copy of the slide deck, Darren, and thank you for loving Chis, Abigail. And I have a direct message from Lainey. Yes, I hope we can reconnect again, and good luck in your dissertation defense.
Before we kind of close out or take a question, can we all just take a picture for our purposes, if people can turn on their camera if they can? I don't know how to take a picture, but Carla,
I can do it.
Okay.
What?
All right, last call. If anyone's turning their camera on. Ready? 1, 2, 3. All right, we got it.
Wait, I'm gonna take a picture too. Sorry, and I can't do it with. I'm just gonna do it with my camera. Yay! Thank you.
Okay. So a quick question, if not, we can let everyone go. Anyone? Last calls?
We
There.
have one raised hand. Yep.
Yeah.
Hey, Dr. Ponce, thank you so much for this lovely talk. I really appreciated it. I think my question is, I guess maybe it's not a question, but just trying to do some observation. So with your work with data equity, how do you see that tied with the push for open science in general? I think I see it as similar, but I imagine that there might be some distinctions among the two different efforts.
Well, why don't you tell me what your definition is of open science?
Yeah, I think that's actually tricky because I think it varies a lot. And I think it sounds like open science could be similar to data equity on how you describe that the data that are collected, analyzed, and interpreted, it should be distributed for with a particular focus on marginalized communities. I think that's where the distinction seems to differ, is that open science is for all versus data equity, it has a target to marginalized communities.
Right, exactly, you got it. It's not about everybody has liberties, everybody has rights. It's about, well, we know that the production of inequities is based on the marginalization of folks because of policies, because of history, because of colonialism, because of policies that are exclusionary. So it's not just about, yes, we're free for all, but it's about we're free for all plus. We had to do more effort for those that, that just don't get the care. And we saw this with the ACA when there was expansion of coverage. The Affordable Care Act was, sure, coverage went up, but in some ways, because of narrow networks, because of confusion, because of how providers are reimbursed through the Medicaid program and who see mostly poor patients, that you still weren't getting, you still were generating health inequities. But yeah, I think it's that piece that's really the clincher here in data equity.
Yeah, thank you so much.
Great question, thank you.
Okay, so Dr. Ponce, you have to go right now, right? So thank you so much for speaking with us today. Absolutely amazing talk. If you could share your slide deck with me, I'll kind of disperse to whoever wants it. But yeah, thank you so much. And then thank you for everyone for coming today's session. And if you came into the last few sessions also, thank you very much as well. So yeah, that concludes today's session.